Welcome to the Deep Dive, where we really try to distill the critical insights from complex research. And today, we're tackling a public health challenge that, well, maybe doesn't always get the spotlight it deserves: congenital cytomegalovirus, or CCMV.
Mm-hmm.
For those of us in prenatal and neonatal care, its impact is pretty striking. It really is the leading infectious cause of birth defects and childhood disabilities, certainly here in the U.S.
Yeah, affecting thousands of kids every year. The potential for severe neurological issues, hearing loss. It's significant.
Exactly. Often more prevalent than things like Down syndrome or fetal alcohol syndrome, which
Sure.
might surprise some people.
It often does.
So our goal today is to really dig into the complex landscape of managing CCMV infections.
Mm.
We want to unpack the latest research on diagnosis, prognosis, and treatment strategies. Basically, give you a concise but thorough overview.
And we've pulled together some pretty robust sources for this. We're looking at key reviews on CCMV and pregnancy, some really fascinating studies on cytokine profiling in amniotic fluid,
Oh yeah, that's definitely an interesting area.
isn't it? And also critical clinical trials on treating it in utero with valsiclover. The idea is to pull out the most important, nuggets of knowledge from these high-level documents, give you a clearer picture of where things stand.
Okay, great. So let's start by grounding ourselves. Just how widespread is CCMV, and what's the range of outcomes we're looking at?
Well, globally, it affects somewhere between 0.5% and maybe up to 2% of live newborns. That's quite a range. And the really challenging part is the variability in how severe it is.
Right.
You can have cases that are completely asymptomatic. The baby seems perfectly fine at birth. But then you have the other end of the spectrum, severe neurological disabilities, or even, tragically, perinatal death.
That variability definitely complicates things. And what about the long-term picture, beyond that initial presentation at birth?
That's where the real burden often lies. Around 20% of babies infected will end up with neurological or audiological problems down the line.
20%, wow.
Yeah. And while maybe 12, 13% are symptomatic right at birth, a really significant chunk, maybe 40, 50%, develop at least one long-term issue. And importantly, that includes about 13.5% of those who looked completely asymptomatic initially.
So asymptomatic at birth doesn't mean you're in the clear?
Not at all. It really highlights the kind of insidious nature of this infection.
And within those long-term problems, you mentioned hearing loss, sensorineural hearing loss, SNHL. That seems to be a major one.
Absolutely. It is the leading infectious cause of non-hereditary SNHL in children. It affects somewhere between 7 and 15% of all infected kids.
And I imagine it's higher in those who were symptomatic at birth.
Much higher, yes, 30 to 60% in the symptomatic group. But still, a significant 5 to 10% of the asymptomatic babies will develop it too.
Okay.
And the real kicker with CCMV-related hearing loss is that it's often progressive, and it can be late onset.
Meaning it doesn't show up right away.
Exactly. A child could pass their newborn hearing screen, no problem, but then develop hearing loss months or even years later, which makes early detection, really tricky.
So timing seems absolutely critical here. When during the pregnancy is the risk for these severe outcomes highest?
Yeah, this is a really crucial point for counseling. The evidence strongly suggests that the most severe sequelae, the serious long-term problems, are almost exclusively linked to maternal primary infection occurring before 14 weeks of gestation.
Before 14 weeks.
Right. There was a large study, 250 children, that found no long-term sequelae if the mother's primary infection happened in the second or third trimester. So there's this really critical window of vulnerability early on.
That's vital information. Okay, let's shift a bit to the virus itself. Human cytomegalovirus, HCMV. What are its key features?
So HCMV, it's a DNA virus, and its hallmark is establishing lifelong latency. Once you're infected, it's essentially with you forever. In people with healthy immune systems, it can reactivate, but usually without causing symptoms. But in immunocompromised individuals, it can cause really severe disease.
And how does it actually get from the mother to the fetus?
Well, the virus sheds in body fluids, urine, saliva, breast milk are common ones. And it's important to remember people can get reinfected with different strains too.
Ah, okay.
Vertical transmission, so mother to fetus, happens through maternal viremia virus in the mother's blood. Interestingly, the risk of transmission actually goes up later in pregnancy.
Oh, really? But the severity is worse earlier.
Exactly. Higher transmission risk later, but highest severity risk if that primary infection hits in the first trimester. Other factors matter too, like younger maternal age seems to correlate with higher risk, and the mother's specific immune status plays a role we're still fully understanding.
And thinking about the damage it does, particularly to the brain,
Hmm.
what's happening at the cellular level?
Well, CMV has what we call neurotropism. It likes brain cells, particularly neural stem cells and precursor cells.
The developing ones.
Precisely. And when it gets into these cells, it can really mess with their normal development. It can alter their cell cycle, stop them from differentiating properly into mature brain cells. And that disruption is what leads to the developmental abnormalities we see.
Okay, that makes sense. So with that background, let's get into the diagnosis side. It can feel like a bit of a maze sometimes. How do we usually diagnose a primary infection in the mother?
Yeah, it relies heavily on serology, looking at antibodies in the blood. You're looking for either seroconversion, where someone goes from negative to positive, or a specific pattern of IgG and IgM antibodies.
Okay.
The generally recommended strategy is to test for both IgG and IgM first. If the IgM comes back positive, then you'd follow up with an IgG avidity test.
And what does that avidity test tell us?
It's really helpful for timing. Low avidity typically points to a recent acute infection, usually within the last 3 months or so. High avidity suggests a past infection, something that happened more than 3 months ago. The automated tests are pretty good, usually high sensitivity and specificity. But, there are pitfalls. You can get false lows, false highs, or these kind of indeterminate intermediate results, especially if you test very early in pregnancy.
Given what you said about that critical first trimester window for severe outcomes, how does that affect the timing of maternal screening?
That's a key takeaway from the sources. Routine serology screening done after 15 weeks of gestation. It's not really relevant for picking up those pregnancies at highest risk for the severe long-term sequelae.
Because the damage might already be done or the highest risk period passed.
Exactly. The real focus needs to be on identifying that primary infection within the first trimester. That's when knowing the status is most critical for potential intervention or closer monitoring.
And just to clarify, what about testing for CMV DNA in the mother's blood, say, before an amnio? Is that useful?
Generally, no. Maternal PCR testing isn't considered prognostically relevant in the same way before amniocentesis. The amniotic fluid itself is where we look for direct evidence of fetal infection.
Right, so that leads us to fetal diagnosis. If maternal infection is confirmed, amniocentesis is a key step.
It is. It's the gold standard for confirming fetal infection. But timing is important here too. You want to do it at least 6 weeks after the presumed maternal infection and also after 17 weeks of gestation.
Why those timings?
Waiting allows enough time for the virus to potentially cross the placenta and replicate in the fetal urinary tract, making it detectable in the amniotic fluid. Doing it after 17 weeks also improves safety and diagnostic yield. When timed right, sensitivity is pretty high, around 85–95%.
Is there a chance of missing it even then? A false negative?
There is, yeah. About a 5 to 15% false negative rate, often thought to be due to late transplacental passage. But here's an interesting point. Babies born after those false negatives, they typically don't develop long-term sequelae.
Hmm. So even if the virus gets across later, it might not cause the same level of damage.
It seems that way. Suggests that early direct transmission is more clinically significant for severe outcomes.
Okay. Beyond amnio, what about ultrasound? What signs might we see?
Ultrasound is crucial. You can see a whole range of things. Extracerebral findings like an enlarged placenta, enlarged liver or spleen, bright-looking bowel, growth restriction, fluid around the heart or lungs, even hydrops fatalis in severe cases.
And brain findings.
Yes, and those are particularly important. Things like microcephaly, enlarged ventricles, cysts near the ventricles, calcifications in certain brain areas, and critically, these severe cerebral findings. They seem to occur only when the maternal infection happened in that first trimester.
Tying back to that timing again. How predictive are these findings?
If you see severe cerebral abnormalities on ultrasound or MRI, that's unfortunately highly predictive of a poor outcome. If the findings are more isolated or milder, the prognosis is generally better, although things like partial hearing loss can still happen. And MRI is often better than ultrasound for picking up subtle white matter issues or specific malformations.
You mentioned amniotic fluid earlier for diagnosis.
Mhm.
What about the amount of virus in the fluid, the viral load?
Yes, quantitative PCR on the amniotic fluid is a really important prognostic marker, especially for neurological damage. The data suggests some pretty clear thresholds.
Right.
Well, finding more than 1,000 genome copies seems to be 100% predictive of fetal transmission actually happening. And if it's over 5,000 copies, that's strongly predictive of the baby being symptomatic at birth. So it gives us a quantitative way to estimate risk.
That's powerful. But it also, I guess, highlights the limitations when those signs aren't present or for predicting later onset issues, which brings us to neonatal diagnosis and screening.
Exactly. Right now, we typically test newborns if we know the mother had a primary infection, if the baby shows compatible symptoms, or if they fail their newborn hearing screen.
But you mentioned hearing screening isn't foolproof for CMV.
Correct. Because of the late onset nature, universal hearing screening might only pick up, say, 20% to 60% of CMV-related hearing loss. So many cases are missed initially. The definitive diagnosis in a newborn is still CMV PCR, usually on saliva or urine, collected within the first 3 weeks of life.
Okay. So it feels like there's definitely a need for better tools, especially for predicting outcomes when the imaging isn't severely abnormal, which leads us to these novel biomarkers you mentioned earlier.
Yes, this is a really exciting area, and that study looking at cytokine profiles and amniotic fluid is particularly relevant here. They looked at cytokines both dissolved in the fluid, the soluble fraction, and those carried inside extracellular vesicles, or EVs.
Remind us what EVs are.
Think of them as tiny little packages or bubbles released by cells. They carry proteins, RNA, other molecules between cells, basically intercellular messengers, and they can concentrate biomarkers, making them potentially easier to detect.
Okay, so what did this cytokine profiling study find? Any strong links to infection?
They found what they call nominal associations between CCMV infection and increases in several soluble cytokines, things like IP10, IL-18, ITAC, TRAIL, and also EV-associated IP10. But the really significant one was IP10.
Why significant?
Because it reached the threshold for statistical significance even after correcting for multiple comparisons, the Bonferroni correction, and it was associated with both the presence of infection and its severity. That makes it a very strong candidate marker.
Okay, so beyond just infection, did these markers tell us anything new about predicting severity?
They absolutely did. Severity was nominally linked to increases in 12 different cytokines. And there seemed to be a specific pattern for the severely symptomatic infections, increases in 6 specific proteins like soluble IL-18, soluble TRAIL, and various forms of CRP, MIG, and RANTES, some inside EV, some outside.
A complex signature.
Very. It suggests a particular kind of immune response, maybe a Th1 polarization happening in those severely affected fetuses. It's a clue about the underlying biology and potentially a much more nuanced way to predict outcome than just looking at viral load alone.
That's fascinating. Were there any surprises in that study? Things that weren't predictive that maybe you'd expect to be?
Yes, interestingly, in this specific study cohort, the amniotic fluid viral load and fetal liver function tests didn't actually correlate with fetal symptoms, which does contrast a bit with some broader understandings.
Hmm.
Though fetal thrombocytopenia low platelets was linked to severe infection in their group, it just highlights, the complexity and maybe cohort differences. But the bottom line is these cytokine findings really boost the potential for using amniotic fluid biomarkers to get a much better handle on predicting both infection and severity, which could really change prenatal counseling.
Definitely sounds promising. What needs to happen next to bring this closer to clinical use?
Well, the key first step is replication. These findings need to be confirmed in larger groups of patients, ideally looking at earlier gestational ages too, like around 17 weeks.
Right.
And there's also excitement about using newer ultrasensitive technologies like single molecule counting or Simoa. These might be able to detect really low levels of these cytokines, especially the ones inside EVs, potentially allowing even earlier or more precise predictions.
Okay, very interesting. So, shifting gears to interventions, prevention is obviously ideal. How effective are simple hygiene measures in stopping moms from getting infected in the first place?
They can be surprisingly effective. The sources really emphasize basic stuff, thorough hand washing, especially after changing diapers, and trying to avoid sharing saliva or urine with young children, not sharing utensils, pacifiers, that sort of thing.
And does it make a real difference?
It seems to. One study showed that focusing on these measures dropped the primary infection rate in pregnant women from about 7.6% down to just 1.2%. That's a huge reduction.
Wow. And when should this education happen?
This is critical. It needs to happen before pregnancy, if possible. Counseling women at their first big prenatal visit, maybe 11 or 12 weeks, is often too late to prevent those early infections that carry the highest risk. So preconception awareness is key.
Okay. Now, what about treatment during pregnancy? There's been a lot of talk about valociclovir. What did that phase 2 study show for fetuses already known to be infected and symptomatic?
That study was quite striking. They used a high dose, 8 grams per day, of valociclovir, and they found it significantly increased the proportion of babies who were asymptomatic at birth It jumped from 43% in their historical comparison group up to 82% in the treated group.
That's a big difference. Did it affect the virus itself?
Yes, it also led to reduced viral load in the fetal blood and improvements in fetal platelet counts, which are good signs of reduced disease activity.
Was it tough for the mothers to take that much? 16 pills a day sounds like a lot.
It is a lot, but remarkably, the tolerability was reported as excellent for mothers, fetuses, and newborns, and adherence was really high, over 90%, despite the pill burden.
That's encouraging. And were these findings backed up by other analyses?
Yes, an individual patient data meta-analysis reinforced this. It confirmed that valacyclovir at 8 grams a day significantly cut vertical transmission rates from about 25% down to 11%, and also reduced the rate of babies being CMV positive at birth from around 41% to 19%. This was particularly for infections acquired really early, periconceptionally or first trimester.
That's substantial. Did it influence the really difficult decisions parents sometimes face, like termination?
This is perhaps one of the most profound findings. The meta-analysis showed a significant drop in terminations due to severe CMV-related problems from 4.5% down to just 0.9%.
Wow.
And again, the effect was strongest for those first trimester infections, the highest risk group. And across the board, the studies found that starting the valacyclovir earlier in gestation was a major predictor of success. Better prevention of transmission, infection, and termination. Early intervention really seems key.
Now, these studies, while really promising, weren't randomized controlled trials, were they?
Yeah,
Due to ethical concerns.
that's right. They were open label or used historical controls, which is an important limitation when we think about the strength of evidence. Ethically, randomizing potentially affected fetuses to placebo is very difficult.
So how do we get stronger evidence?
The idea of a cohort, multiple randomized controlled trial design has been floated. It's a complex design, but it might offer a way to get more rigorous comparative data within an ethical framework in the future.
Okay. What about after birth? If a newborn is symptomatic, what's the role for antivirals then?
For symptomatic newborns, drugs like ganciclovir or its oral form, valganciclovir, are used. There was one key RCT showing that a 6-week course of ganciclovir prevented hearing deterioration at 6 months.
So it helps with hearing.
It seems to help prevent worsening in the short term. But the long-term picture for hearing thresholds is actually still quite complex and maybe not as clear-cut. Many children treated still require significant audiological support and rehabilitation later on. So it helps, but it's not necessarily a complete cure for the hearing issues.
Right, it's complicated. Finally, let's look ahead. The ultimate goal for many infectious diseases is prevention through vaccines. Where are we with the CMV vaccine?
It's definitely a major public health priority, but CMV is a tough target. It's a large, complex virus, very adept at evading the immune system. So vaccine development has been a long road, and unfortunately, there's no licensed vaccine available yet.
But there is work being done. What kinds of candidates look promising?
Oh, yes, definitely progress being made. There are several promising candidates in early stage clinical trials. Things like enveloped virus like particles, known as EVLPs, often focusing on the GB protein. Also, live attenuated virus vaccines and the newer mRNA vaccines, similar to the COVID vaccines, targeting both GB and another key target called the pentameric complex.
And animal models are important for testing these. You mentioned the guinea pig model earlier.
Absolutely critical, especially the guinea pig model, yes.
Yeah.
Its placental structure is quite similar to humans, and importantly, guinea pigs infected congenitally can develop sensorineural hearing loss just like humans.
Ah, so it mimics that key outcome.
Exactly, which makes it invaluable for testing whether a vaccine candidate can actually prevent congenital transmission and disease, providing crucial preclinical data before moving into large human trials.
Strategically, who would we target with a vaccine?
That's a big question. For adolescents, you'd need long-lasting protection to cover them through their childbearing years. But there's also a lot of discussion around potentially vaccinating preschool-aged children,
Why preschoolers?
because they are a major reservoir for CMV and a common source of infection for pregnant women, often through contact with urine or saliva. Vaccinating them wouldn't just protect them, but could potentially reduce transmission throughout the community, protecting expectant mothers indirectly. It's a complex strategy, though.
That really sounds like it. So as we wrap up this deep dive, it's just so clear that our understanding of congenital CMV is incredibly dynamic, isn't it? Constantly evolving.
It really is. We've touched on how these advanced diagnostics, especially the potential of cytokine profiling, combined with promising treatments like in utero valacyclovir, are really starting to refine how we approach this infection.
Yeah.
But while we've made huge strides, that ultimate goal of widespread prevention through vaccination is still on the horizon. It just underscores the need for continued research, continued innovation.
Absolutely. So, as you, our listeners, think about all these insights on CCMV, here's a final thought to mull over.
Uh,
Considering everything we've discussed, the complex biology, the potential for late onset problems like hearing loss, how might integrating these newer biomarkers and earlier interventions actually change how we even define an asymptomatic infection? And what could that mean for how we approach long-term follow-up and personalized care for these children in the future?